Hello, everyone. This is Dr. Amigues, your friendly rheumatologist. And I'm almost on time at 11 for our next live. So I'm going to present myself. It's been a while. So I'm a rheumatologist. I'm French, as you can hear. I've done my training in France first in Paris, and then I did my residency and fellowship in Lyon, where I chose rheumatology. And then I moved to the US for research as well as to start a family. And I ended up in New York City. I repeated my residency and fellowship, did my fellowship at Columbia University, and then moved to Denver, Colorado, where I did a lot of research at National Jewish, loved it. And because of a health scare that I had myself, with cancer, I kind of changed a little bit how I practice medicine. And because of that, the insurance system just wasn't aligned anymore with how I wanted to practice medicine. And that is how I developed Unabridged MD. And that is what I started a year and a half ago. And so those lives are part of Unabridged MD because for me, it's about healing the mind, the body, and the spirit. And one of the ways to heal spirit is to create a community. And I think that education is part of how we create communities. So that's it. Today, we're going to talk about ankylosing spondylitis. It's actually a question. I'm going to find where it is from. Who asked me this? Vasil Onityu. I'm so sorry if the name is not said like that. That was on YouTube. And basically, please share some info about ankylosing spondylitis. So that's what we do today. So as you can hear, and hi, PUBG Live PK from Pakistan. Very nice to see you. But yeah, so basically, if you are watching this on live, come and say hello. And if you're watching this on replay, please put a hashtag replay so that it's being uplifted, because I think that we need more physicians on social media. I have a love-hate relationship with social media. I hate it because I think it's a time-consuming machine, but I also love it because I learn a lot, and I think that I've 17 years of studying, and so I'm really happy to put it to the service of the community, so that you guys can learn and can see how we think as rheumatologists. All right, so without further ado, let's talk about ankylosing spondylitis. And I'm going to share with you a recent case, because it's almost like a typical case. So I had a patient of, I think he was late 30s who presented to me with back pain. And basically just the pain was just, someone told them, you're having a lot of back pain. Have you ever seen a rheumatologist? And I was like, no, I don't like doctors, and decided to come and see me for evaluation. And when we digged it a little bit further, it turned out he had back pain since his early 20s. And the pain was what we call an inflammatory back pain. So remember, when I say that, what I mean is that it's back that's worse in the morning, that's associated with morning stiffness, and that improves with exercise. And so one of the ways that he was coping with that is that he was doing a lot of sports. So he would run, he would do yoga, he would swim. And so basically his whole thing was like, well, I'm not feeling great in the morning. And one way that I found to help is to work out right away so that then I feel better, okay? So this is actually really important from a rheumatology standpoint, because for us, that's how we can say, okay, this is an inflammatory back pain. And that's how we start like thinking, okay, what can this be? So because of the inflammatory back pain, and there was no other joint pain, there was a little bit of a heel pain. So of Achilles tendon. So, I'm going to use that. If this is your foot, and this is your ankle, at the association between your foot, the heel, and the ankle, you have a tendon that can get inflamed. And so that's actually a good sign of spondyloarthropathy. Okay, so then we did x-ray, so examine the patient. There is this pain of the back, sacroiliac particularly, so that's the low back. And then there is this pain at the insertion of the tendon to the heel, okay? And then we do x-rays, and the x-rays of the sacroiliac are showing complete fusion of the sacroiliac, okay? By itself, just that is enough to say this is ankylosing spondylitis. And it is really, like, I want to talk more about ankylosing spondylitis now, because basically it is actually not well diagnosed. What I mean by that is that it takes on average between 7 and 12 years to diagnose ankylosing spondylitis, because people are going to develop back pain when they are in their early 20s, early 30s, even 40s. Usually it starts before 45. And then they basically live with it. They take some anti-inflammatories such as ibuprofen, Aleve, and they feel better with it. And so they don't think of it more. And what ends up happening is that you can have then progression of the disease if you don't actually do anything about it. And then at one point you're like, okay, this pain is actually like really problematic and cannot, like, I don't know what to do with it. I need to do something. Maybe the ibuprofen that used to work is not working anymore. So what is ankylosing spondylitis? So ankylosing spondylitis is an inflammatory back pain that basically is part of something that we call spondyloarthropathy. Very fancy name, but it means nothing. You're going to see. Spondylo means spine. I think it's Greek. Pathy means disease. So disease of the spine, okay? And so what it is that you're basically good, like you're saying, okay, there is, because of this inflammatory back pain, you're saying there is a spondyloarthropathy, and then you're going to try to see which type of spondyloarthropathy there is. We usually differentiate between non-radiographic and radiographic. So in the case of this patient, he has radiographic because on the x-ray, we can see complete fusion of his sacroiliac. The vast majority of people, and hopefully that is the case because we don't want to have that, the vast majority of people will have very limited changes on x-ray. And very often you make a diagnosis with an MRI where you see an inflammation of the sacroiliac. The truth is that there are some patients that won't have anything, but they'll have other type of conditions. So they may have psoriasis. Sorry, it's not said the same thing in French and in English. So psoriasis in French and psoriasis in English. So sorry about that. So it's, a skin disorder. So if you have that and you have an inflammatory back pain, you have psoriatic arthritis, and that is a form of spondyloarthropathy. So you can have that. And then sometimes you don't have, we don't know, you may have an inflammatory bowel disease that's associated. You have so many other reasons. And so when we are looking at patients with inflammatory back pain, we always ask them different questions so that we can make sure they don't have other type of condition. My hands here are basically showing round circle. And imagine a Venn diagram. Oh, I can't remember. Sorry, I'm good in medicine and in rheumatology and some of those. I think it's called Venn diagram. Anyway, like those circles that are together. I don't know why I have a blank on how you say that. But anyway, so if you have an inflammatory back pain, you want to know, have you had eye inflammation? Do you have uveitis? Then do you have inflammation of your bowel? Because that inflammatory bowel disease. Do you have psoriasis, psoriatic arthritis? Do you have any urine issues? Can pee, can see, can climb a tree is how we make a diagnosis of reactive arthritis, because they'll have eye inflammation, they'll have urine, like a urethra. So basically when they pee, it's really painful. And they have joint pain. That can be, and so all of those, in these diagrams, they can be associated. And so when you're picking up on one of those where there are some symptoms, like in this case, inflammatory back pain, you want to make sure that you're picking up those other ones as well, okay? And then you're going to do some blood work as well. So you're going to check HLA-B27 to see if there is the possibility of ankylosing spondylitis HLA-B27 positive. That said, and this is an answer to Eladia Lopez that's asking me, and she's saying, I was diagnosed with this 2 years ago, an MCTD and Sjogren. You're not a mess. You are not. And I am HLA-B27 positive. So what's really important is to realize that HLA-B27 does not make a diagnosis of ankylosing spondylitis, because you want to make sure that you also have this inflammatory back pain. If you don't have inflammatory back pain and you have the HLA-B27, then we know that 5% of the population is positive for HLA-B27. On the other hand, you can have this inflammatory back pain, have the complete fusion of the sacroiliac, and be HLA-B27 negative, right? So always remember that there's a reason why medical studies are so long. Again, I have 17 years, right? And I keep learning and I keep being very humbled by medicine, because it's an art and it's not all black and white. If it had been the case, AI would have taken over. And it has not. And I don't think it's ever going to. It's going to help us, but I don't think it has. And so when you have an HLA-B27, remember why you checked it, okay? So that's important. Now, that being said, we can have autoimmune disorder link that's called overlap syndrome. In the case of ankylosing spondylitis, unless you have all of those things that I was telling you, like the uveitis, the inflammatory bowel disease, that's usually what it is associated with. It's usually not associated with MCTD or Sjogren, just FYI, okay? All right. So there's a lot of comments. I'll go over after that, guys. So in the, just to answer the first question, which was about ankylosing spondylitis, how, when we see this, so right, so if we go back to the case of my patient, he has ankylosing spondylitis, the diagnosis is made, his sacroiliac are completely fused on X-ray, and he has this inflammatory back pain. I do think I know he's actually between 7, so that's like easier to make a diagnosis. But even if he was negative for HLA-B27, I'm fine. He still has ankylosing spondylitis. Now, how do you treat this? So the goal is to prevent further damage. So further ankylosis, which basically means that you can't move as much, right? So we're preventing that with our medicine. And so this is where there's a really good news, is that the first treatment for this is an anti-inflammatory or non-steroidal anti-inflammatory, such as ibuprofen, diclofenac, Aleve. And so you try that first, and we usually say that you have to try 3 of them. Most of the time, the vast majority of our patients, when they come to us, they've tried at least 2. So they've tried ibuprofen and they've tried Aleve. And so then you just try another one, such as meloxicam, diclofenac, we have so many, right? Indomethacin. And if the third one doesn't get to full remission, remember our goal is always full remission, so no more pain, no more morning stiffness. And if we don't get there, then we have to go to the next step, which is usually a biologic. And biologic are usually TNF inhibitor. That is how we start, okay? The vast majority of time, I will have to say, is that you're able to go into full remission with an NSAID and exercise. And when I'm saying exercise, it's like stretching exercise. So if there is one thing that you can do at the end of this this live, is to remember that you have to move. And one way to move when you have inflammatory back pain is to make sure that you're stretching. So you can do some yoga poses, you can do some stretching, you can rock climb, because that's going to actually stretch you, and things like that, because that is actually going to help and it's going to move your body. And that is what we recommend at this time for patients with ankylosing spondylitis, okay? So in summary, if you have an inflammatory back pain, you want to check HLA-B27 X-rays of the sacroiliac. If the X-ray of the sacroiliac is normal, you go and you do an MRI of the sacroiliac. And then you start NSAID, such as ibuprofen, meloxicam, Aleve, and you also do exercise that are going to stretch you. Okay. All right. So couple of discussion. 2202, hi. And then hi to PUBJ, Eladia, and I'm sure I'm going to have some, like we always have some replay. I know this is not the best time for the day, but it works for me. And then if you have a better time, you can tell me and I can try to make it work. But for now, it seems to work. And yeah, if you have more questions, so yeah, we wanted to discuss some of those things. So my mom is a patient of rheumatoid arthritis from 10 years, and now she's 58 years old. Yeah, so rheumatoid arthritis, a different type of arthritis that affects more like the peripheral joint, and is usually not something that we take that long to make a diagnosis of, because again, NSAID is not going to be just enough, and usually you need more than just NSAID. You need like an actual disease-modifying anti-rheumatologic disease drug. But yeah, we have super good treatment for rheumatoid arthritis as well. In general, when you have a rheumatologic disorder, you can be very optimistic about the fact that we would get you to full remission. Okay, so that's really important. All right, guys, it is already more than 15 minutes, and I try to keep those short. Have a wonderful day, and I will see you next week. Take care. Bye.